Hi everyone, welcome back. We are going to be covering genetic testing, some certain syndromes, some procedures that are involved with making sure we get precise, detailed information about the developing babies in the OB world. So we kind of talked about this a little bit in that first trimester development. When you're going through those very early stages of pregnancy, you have a lot of testing that's done really early on. And then as we get closer into that late second trimester and third trimester, we're not really doing too much testing beyond that. That first trimester is really going to be the informative period where we're looking for answers. We're looking to make sure that the health of that pregnancy and the mom are going to sustain for the rest of that gestation. So that first trimester is super important. So before we get to some of those specific tests, we do need to have an understanding of just basic genetics, emphasis on basic. This is not something that you need to get crazy with. This is not something that the boards get super in depth with, but you need to know what these specific terms mean. So a normal, healthy human being, typically we reference this as euploidy. So that is when we have 2 pairs of 23 chromosomes per pair. So we have 46 total chromosomes in a normal genetic makeup. So this means that anything that varies from that 2 pairs of 23 is going to be an abnormality. When we have an extra chromosome, regardless of what pair it's in, so we have 47 chromosomes instead of 46, we consider that a trisomy condition. When we have an entire extra set, so we have 48 chromosomes, we're going to consider that triploidy. When we have a missing chromosome, again, regardless from which pair, that's going to be aneuploidy. Ane, remember, it means missing. So we have 45 out of 46. And then we have to know what our types are. So our genotype is kind of the overall kind of blanket statement that we give to our genetic composition. So really kind of just the broad term that we're using. Breaking it down a little bit further is karyotype and phenotype. So the phenotype is going to be our entire physical and physiologic makeup, which is usually going to be determined by our genetics, but also our environment. So a lot of those, like when we were learning about our abdomen pathology, a lot of those conditions that are more prevalent in certain types of communities or certain aspects or locations in the world, geographic locations, that's going to be that environmental impact. So phenotype is our genetics, but also the impact of the environment that we are developing in. And then our karyotype, this is going to be referencing a complete set of chromosomes in a cell. So kind of the overall cellular composition of our DNA. Getting into that genetic testing, like we said, first trimester, super important. Really have a particular window of time to get these tests done, because after a certain period of time, these tests become highly inaccurate. So we're usually doing our first trimester testing anywhere between 11 to 14 weeks. Some genetic tests, you can have it done a little bit earlier. So you may see some people going for blood work maybe a little bit closer to 9 weeks, and that's usually okay, but sometimes they have to come back for repeat testing. So we're usually kind of in that sweet spot of 11 to 14 weeks where you're going to have a lot of this bulk testing done. Usually this is going to include a nuchal translucency exam. So we're looking at that nuchal translucency behind the baby's neck, making sure that it's not abnormally thickened. We will talk about that a little bit later on. We're also doing a blood test. With the blood test, we're getting a lot of information. So it's kind of scary how many vials they actually pull out when you go for your first trimester testing. I think there's anywhere between like 9 and 12 vials of blood that they take, because they're looking for all of these different markers. So they're looking for our beta HCG, so our human chorionic gonadotropin in our blood. Remember, beta is referencing the blood level. And then we're also looking for PAP-A, which is an antigen that we see in early pregnancy. We're also looking to evaluate those trophoblastic tissues, which are going to be responsible for producing that beta HCG and that PAP-A. We're looking for low level, we're looking to make sure that none of these levels are low, because that can indicate certain types of trisomies or poor outcomes for the pregnancy itself. The blood test is really sensitive for early detection of trisomy 21 and trisomy 18, which we'll talk about in a second. We also have some additional genetic markers that that blood test is looking for. These can kind of be pushed out a little bit later on in that kind of first trimester, early second trimester period. So that's why usually if people are going for blood work at 9 weeks, we're going to have them come back a few weeks later to get this additional blood work done. So if you're kind of in that sweet spot of like the 15-week gestation, you can usually get all of these blood tests done at once. But for the most part, people are really anxious, they're really nervous, or they're really excited when they get a positive pregnancy test. So they're going to get the initial blood work done where we're looking for the beta HCG and the PAP-A, and then they're going to come back a few weeks later to get these additional tests pulled with their blood sample. So we're really looking for maternal serum alpha-fetoprotein, and we're also doing a quad screening with blood between 15 to 21 weeks. So in that sweet spot of 16 to 18 weeks, in that range, we want to try to get both of these done. So MSAFP, we said, is maternal serum alpha-fetoprotein. We're literally, it's telling you what we're looking for. We're looking for the alpha protein of the baby from the mom's blood. So this is going to be a blood screening test that helps us to indicate if there's any risk of genetic disease or birth defects for that pregnancy. And then the quad screening, we're still looking for the alpha-fetoprotein, and then we're also going to be looking for estriol, inhibin A, and HCG with that. Some quad or some physicians will usually only do the quad screening. We'll only do the quad screening. But if you have a little bit more of a thorough OBGYN, or you want to have a lot of excess genetic blood work done, you would get both of these. So the MSAFP is usually going to be for somebody who is low risk for genetic conditions or diseases. If you have a little bit of a higher risk of genetic conditions or diseases, you would definitely want to be getting the quad screening as well. So it's giving us a little bit more information than just the MSAFP. So we're, looking at that as a whole. And again, remember, this is going to be done a little bit later than that initial blood work confirmation that we have with that earlier blood sample. When we have these genetic tests done, we said that the AFP is going to be a big indication of what is going on in terms of genetic issues with this pregnancy. We also kind of talked about PAP-A, inhibin A, estriol. All of those things, of course, are going to indicate potential problems with genetics with the baby, but the AFP is going to be kind of the first thing that we look at, and that's usually going to be the telltale sign of if something is wrong. Now, you can have a lot of reasons as to why you may have abnormally increased AFP or abnormally decreased AFP. You want to have an appropriate level of AFP based off where you are in the pregnancy. So if you have a really high level of AFP, yes, there could be something wrong genetically. We could have an open neural tube defect. We could also have abdominal wall defects, which we'll talk about when we get into fetal abnormalities in a few weeks. You also could have that be indicating some sort of liver disease with the mom, or hepatocellular carcinoma with the mom's liver. We could have some kind of hemorrhage going on with that early development of the placenta, so that maternal-fetal relationship could be bleeding. We could have a chorangioma in the placenta, which again we will learn about as well, or we actually previously learned about in our extrafetal assessment. We could have our dates wrong. We could be further along, or we could think we're further along than we actually are in our pregnancy, and that's going to indicate an abnormally high AFP. We could also have multiple gestation pregnancies, so we could actually be pregnant with twins. And of course, if there's two babies in there, we're going to have higher levels of AFP in that blood sample from the mom. Now, decreased AFP conditions that are going to result in decreased AFP are going to be trisomy 21, trisomy 18, and trisomy 13. Also incorrect dates as well, so maybe we're further along than we think we actually are, and fetal demise can result in decreased AFP as well. So again, we want to make sure that clinical history is very accurate. Next, we have a chorionic villus sampling. This is not something that is done routinely. This is something that we are trying to get definite answers. We have a really high risk pregnancy going on. We need to figure out what's going on. We need to get more in-depth detail from this pregnancy without relying on blood work. So maybe the blood work came back abnormal and we still have questions from the blood work. Then we're going to move forward with potentially doing a CVS or a chorionic villus sampling. This is a procedure where we're actually going in and we're trying to take out some of those cells from that chorionic villi. And we're trying to see, okay, what is actually going on with this fetal tissue? We had abnormal blood work. Okay, yeah, great. But now we really need to know what is going on with the developing tissue itself. So this is something that we have to be okay with the risk associated to it. There is a 1 to 3% risk of fetal death. So if we are looking at a really severe case of trisomy 13 or trisomy 18, then you have to kind of weigh your options. You have to kind of weigh, do I want answers, potentially risk the health of this pregnancy, which may already be at risk, or do I let this pregnancy go and whatever the outcome is, whatever the outcome is. So this is something that a lot of women have to make their own personal moral decision regarding. This is not anything for us to be judging. This is something that you as an individual and only you can make the decision for yourself and for that baby. So these are things that we need to be sensitive about. We can usually only perform this in the first trimester, so 10 to 12 weeks gestation is kind of that sweet spot. We're not going to be doing it any later than that. If we were to be doing it any later than that, we have some different tests that we may do to get some additional information. So amniocentesis is one of those exams that we can do a little bit later on than the CVS. This is something that's actually going to go in and we're going to be able to aspirate some amniotic fluid and test that to see what's going on with those fetal cells. Originally, the purpose of an amniocentesis was therapeutic. So we would go in and we would try to aspirate when a patient or a baby had polyhydramnios and they had too much amniotic fluid that it was putting the baby at risk. We could go in and take some of it out. But now we're also using it for genetic information. We're using it to determine RH compatibility with the mom, that rhesus factor, that blood condition between the baby and the mom. And we're also using it to help us to determine fetal lung maturity. So in a lot of cases where there is a risk of preterm labor or a baby being born way earlier than they should be, one of the most important things with the preemie baby is that their lungs are developed. We can test their lung development and their lung maturity from the byproducts that are in the amniotic fluid. Babies practice breathing by that amniotic fluid. So we would be able to see the proficiency of their lungs in that cellular level. But we're also, like we said, using this to help get more genetic information as well a little bit later on in that late first trimester, early second trimester. Again, there is a risk of fetal death, so not every patient is going to want to go through this process, about 1 in 400 pregnancies. And if you have a multiple gestation and you have 2 sacs, meaning you have anything other than a mono, you would sample each sac individually for the twins. Nuchal translucency. So there is a lot of competing literature on the criteria of a nuchal translucency exam, and it's something that, depending on where you work, if you're interested in working in an OB office, you may have different criteria to follow than this. So this is kind of like the standard information, but just know that there's variations that come with it. This is a type of early non-invasive test for potential genetic abnormalities, usually doing this in that first trimester, 11 to 13 weeks. We cannot perform this exam if the crown rump length of the baby is greater than 79 centimeters or 40 or less than 44. So that is something that that should say millimeters, guys. Sorry, 79 centimeters is pretty big. So anything less than 44 and greater than 79 millimeters, we're not going to be able to get an accurate measurement. We want to make sure that we are measuring the posterior pocket of fluid behind the baby's neck. And the thicker that pocket of fluid is, the more indicative of the chromosomal abnormality it is. So we want to see anything typically less than 6 millimeters for that nuchal translucency. There is pretty good accuracy with ultrasound, but usually we're using this in conjunction with the blood test anyway, so it's kind of just like not an unnecessary step, but it's not super GRUBER necessary. And some physicians don't even do these exams anymore. They just rely solely on blood work. 80% accuracy with ultrasound. We do have a 5% false positive rate, meaning that some nuchal translucencies or nuchal thickness can be greater than 6 millimeters, and they still end up being totally fine in normal genetic composition. And there is a lot of specific technical requirements with performing an NT exam. You have to have the baby positioned in a certain way, away from the amniotic wall, with a certain amount of amniotic fluid. So there is a lot of detail that goes into performing those exams. But just for this PowerPoint, we'll keep it straight to that information. Cell-free DNA. This is a new type of non-invasive test that we can perform, very similar to that first trimester blood work and early second trimester quad screening that we can do. It's basically looking to pull fetal DNA that is in the mom's blood. It's helpful to detect trisomy 21, 18, 13. You kind of see it's a recurring theme here. These trisomies are really, really intense, not 21, but 18 and 13. It has a 97% detection rate, and the only thing that really inhibits that accuracy is when we have maternal obesity. So a maternal weight of more than 250 pounds, we're not going to, not that we're not going to get answers, it's just going to be a little less reliable, and we may just want to do some other follow-up testing for those patients. We also, if we were to get a positive cell-free DNA for trisomy 21, 18, or 13, we can confirm that with that amniocentesis. Again, not something that every patient is going to want to do because of the risk. Next, we are getting into kind of each of those common genetic conditions that we've talked about. So trisomy 13, this is also known as FETAL syndrome. Very unfortunate condition. It's highly unlikely to be compatible with life. So about 85% of these babies are going to die before their first birthday. Awful, awful statistic. It actually occurs about 1 out of every 6,000 live births. So it's a lot more common than we think. On ultrasound, we are going to see holoprosencephaly, which we will learn quite a bit about. We are also going to see intrauterine growth restriction, where the baby is just abnormally smaller than they should be for their gestational age. Baby's also going to have polyhydramnios, where there is too much amniotic fluid in the sac. We're going to see agenesis of the corpus callosum. So as we know, our corpus callosum is that connecting feature in the cerebral hemispheres. If we don't have that, we're not really going to have great cognitive function. We're also going to see micrognathia, abnormally small chin, cleft lip and palate, a ventriculoseptal defect, which is a heart condition, and a single umbilical artery. We know that we should see 2. Physical characteristics of a baby with trisomy 13 is going to be atypical facies. You're going to hear that a little bit. It just means that these babies have a very similar looking abnormal face. They're also going to have hexa or polydactyly, where we have extra digits, so extra fingers and extra toes. They're going to suffer from psychomotor retardation, so they're cognitively going to be a little bit slower, physically going to be a little bit slower, and they're going to have multiple anatomic abnormalities that can vary as well. This genetic testing is really important. A lot of moms can't make the decision to carry a baby to birth that they know has a very high likelihood of not surviving. So this is something that you have to have compassion for. You cannot judge these moms if they decide to have an elective abortion after a trisomy 13 diagnosis. It's something that I am very grateful that I have. Having healthy babies is just something that is incomprehensible. This is something that I don't wish on anybody, and we have to remember that these are extremely hard decisions for these moms and these families. That is why maybe some women would be willing to take the risk of an amniocentesis or a CVS, because if there's a slight chance that their baby doesn't have trisomy 13, I would want to know that and carry that baby to full term rather than know that they do have it and have missed the window of opportunity to not have that baby suffer. So a lot of moral and inner turmoil in terms of decision making with these situations. Here we just have a diagram of that typical appearance of a baby with FETAL syndrome, trisomy 13. Pretty straightforward. Next, we have trisomy 18, which is also known as Edwards syndrome. Again, this is very similar to trisomy 13 in terms of survivability and mortality. About 90% of these babies also are not going to make it past their first birthday. The babies that do typically only live to 5. again, just things that we don't want to have to think about. This is also known as Edwards, like we had said. This is a little less common than trisomy 13, only occurring, more common than trisomy 13, occurring in 1 out of every 3,000 live births. It's going to be a type of primordial growth deficiency. You may have heard of that before. We'll talk a little bit more about those skeletal conditions when we get into that category, but this is basically a type of dwarfism. These are going to result in low levels of HCG, AFP, and estriol. Characteristics of these, again, atypical facies, so facial dysmorphia. We're going to see these babies have severe psychomotor retardation. Like we said, spontaneous abortion is very common in utero, and if they do make it to term, 90% of them will not make it past their first birthday. On ultrasound, these babies are going to have clenched hands, so when you are doing your OB rotation, the sites want to see the palms open, and that's going to indicate that the baby can do that motion. These babies are also going to have IAGR. Like we said, it's a growth deficiency, so they're going to be abnormally small. They're going to have polyhydramnios, micrognathia, a strawberry-shaped head, rocker bottom, which is a foot condition we'll talk about, and omphalocele, which we will also talk about as well. And here are two little sweethearts with that. So cute and so unfortunate. Next, we have trisomy 21, best case scenario of genetic conditions. We all know somebody who has Down syndrome or know of someone who has Down syndrome. This is not something that is worrisome by any means, but it is something that is considered a genetic condition. So this is a random chromosomal event, extremely, extremely common, 1 out of every 710 live births. With testing, we're going to see high levels of HCG, but low levels of AFP and estriol. Characteristics for these patients are going to be that atypical facies, atypical physical appearance, and mental retardation in some cases. I don't typically like that term, but it is a medical term. On ultrasound, the nuchal fold is going to measure greater than 6 millimeters in thickness when we are going for that translucency exam, and it can also be associated with, on ultrasound, a cystic hygroma, diaphragmatic hernia, duodenal atresia, absent or small nasal bone is a really, really big one with trisomy 21 on ultrasound, renal pyeliectasis, myoventricular megaly. So these are all things that we'll learn about a little bit more when we get into specific abnormality systems. So absent nasal bone, that is really only associated with trisomy 21 on ultrasound. There are some false positives with that, where sometimes we think that we don't see the nasal bone, so we indicate that there was an absent nasal bone on ultrasound and they end up not having trisomy 21. So again, not 100%, but still a big indication of that if we were to see it, or rather not see it. Another piece of literature that is still kind of floating around out there, it's old school information, it's not accurate anymore, is an echogenic intracardiac focus. Back in the day when we were just kind of starting to do OB ultrasounds or anatomic screenings in OB, we had a high association of trisomy 21 and a very focal hyperechoic little dot within one of the chambers of the baby's heart. And they were trying to push for literature to show the relationship between the two, but now we just call an intracardiac focus its own kind of random isolated benign thing. It's not associated with trisomy 21. It's not an indication to look for. It is something that if we were to see it on any baby, they'd get a follow-up echo, but it's not anything that we can say is highly associated with trisomy 21 anymore. And here, so cute, I can't take it. Next, we have amniotic band syndrome. So this is something that is not really considered a genetic condition, but it is classified as a syndrome. It's also known as constriction band syndrome. So you may have heard a couple different terms. It's when the amnion in early pregnancy somehow gets disrupted, and we get these bands of that free-floating amniotic sac floating within the amniotic fluid. So it's basically like that inner sac, that inner lining of the gestation sac popped, and now the bands are kind of just free-floating in there. These bands are super, super sticky. so they can kind of trap and they get stuck on different body parts and they wrap around different body parts and they don't come undone. So it's going to lead to cases of limb-body wall complex, which we will learn about, but you can do a quick little Google search on that. It also can result in craniofacial defects where we can get these clefts that come down the baby's head. We can get dysmorphia of the face. We can actually have amputated limbs. We can get visceral complications, meaning that the internal organs of the body then become disrupted. Again, you can do a quick Google search of ectopia cordis, abdominal wall defects, all things that we're going to talk about a little bit later on in the semester, but you should be aware of them right now with these syndromes. On ultrasound, we're going to see very echogenic bands kind of free floating in that amniotic fluid. We may see them actually attached to different parts of the baby, and we're going to see kind of like abnormal position, movement, and development of those fetal structures. When I was a student, I worked second shift at a very busy hospital in Connecticut, and I was kind of finishing up my rotations. The technologist let me in on my own. It was a second trimester from the ER, so it was kind of just like a check and see what's going on, make sure baby is okay type of thing. It wasn't like a full anatomy scan. And she was about 16 weeks, and the baby had amniotic band syndrome that had wrapped around the baby's neck and had decapitated the baby's head, and the baby still had a heartbeat. So these are cases that will stick with me forever. Absolutely awful in those moments. Fortunately, I don't know if that's the appropriate word to use, but I had a technologist who went in and handled the situation. I don't know how I would have handled that situation if I was a brand new technologist. I would hope that I could give the patient the best care possible and have a physician relay that information to her as soon as possible, because it's just absolutely awful. And here you can see in this picture, free floating amniotic band right here. Especially later on in the pregnancy, we know that that amniotic band should be fused with the chorion, so we should not see that much separation. Next, we have Turner syndrome. So this is talking about the karyotype, so a little bit more of the reproductive aspect of genetic composition. This is an XO karyotype, so this means that there is either a complete or a partial absence of the second X in a typical female patient. So you have female genetic makeup, but you don't have that full or even that partial second X. You don't have an XY because that's male, but you have an XO. So it's, your body is kind of just like, I'm 75% genetically a woman, but we're missing that last puzzle piece. So this is not where we get into ambiguous genitalia. This is not where we get into medical hermaphroditism. This is its own genetic condition. This is a type of aneuploidy because we're missing a chromosome. This occurs in every 1 out of 2,500 to 5,000 patients. Characteristics of this syndrome: this is not a life-threatening thing. This is not even anything that people know people have just by looking at them. So the prognosis of this really is just going to depend on the extent of any other anatomic issues going on. Sometimes cardiac and renal abnormalities, especially when we're looking at the reproductive system. If there's something abnormal with the reproductive system, the kidneys are usually close behind that. So depending on how severe your renal abnormalities are, you could have some complications throughout your life. But typically these women are not going to have periods. They're going to be shorter than normal. This is not a form of dwarfism or skeletal dysplasia, so they're just on the shorter end. They usually have a webbed neck. They have a shield-like chest. They have wide set nipples, normal intelligence, poor hearing, and they typically need hormone replacement therapy to maintain their female characteristics. On ultrasound, we can also see lymphedema in the tissues of the baby when they have this. We also are going to see cystic hygromas. That's going to be the most common ultrasound indication of this. Cardiac abnormalities, renal abnormalities. So pretty straightforward with that. Here is what these patients typically look like. Again, you would have no reason as to question gender or anything of that nature with this patient. But you can see on the diagram they are a little bit shorter, they're a little bit wider set in their development, and their reproductive organs, it's rudimentary ovaries, meaning they have ovarian tissue, it's just non-functional. So that's going to be the need for hormone replacement therapy for these patients. They're not going to ovulate, so they will not menstruate, hence why they have amenorrhea. Beckwith-Wiedemann syndrome, this is going to be a group of congenital disorders that we typically see together. So this is when a baby has an omphalocele, macroglossia, and gigantism or visceromegaly. An omphalocele is an abdominal wall defect where the protrusion of the abdominal contents comes through the defect and is encased in a sac. This is usually going to be some sort of genetic condition that we see associated, or kind of like a byproduct of genetic conditions that we see associated with a lot of different things. So we will learn about this quite a bit as we move through the rest of the semester. Macroglossia is an abnormally enlarged tongue, and gigantism or visceromegaly is when these babies are big. They are bigger than normal. These are when we see on the news that a mom gave birth to a 13-pound baby. That is gigantism or visceromegaly. Some additional characteristics of Beckwith-Wiedemann, we're usually going to see heart conditions, the placenta is going to be large, we are potentially going to see chorangiomas in the placenta, we're also going to see postnatal renal tumors, typically that pediatric renal tumor of the Wilms tumor. So again, anything kind of in that genetic region is going to be associated with kidney or cardiac conditions. And here's kind of what these babies look like. This isn't the most accurate image because the protrusion of the abdominal contents is not encased in a sac. There are two different types of abdominal conditions, gastroschisis and the omphalocele, like we said. Omphalocele is going to be encased in a sac. Gastroschisis is not. They are two different conditions, but this would be more accurate if we saw some sort of enclosure around that protrusion. All very fixable. MECKEL-GRUBER syndrome, this is an autosomal recessive condition. It's a very complex chromosomal abnormality, so we're not going to get too in-depth about it. You just need to know that it exists. And usually we're going to see it with an occipital encephalocele. This means we have a protrusion of brain matter at the back of the skull. Again, we'll learn all about that. Polydactyly, extra digits, and bilateral dysplastic cystic kidneys. So again, renal abnormalities. This is rare, and this is usually incompatible with life because of the bilateral kidney condition. And here we're kind of showcasing all three of those. So we have our toes here showing the polydactyly. This one has 6 toes on it. We have the occipital encephalocele, the protrusion of brain tissue out of the back of the baby's skull. And then we have bilateral dysplastic cystic kidneys. You can see the cystic kidneys in this transverse abdomen view bilaterally. Ellis-Van Creveld syndrome, again, another rare genetic syndrome. This is actually very, common, but prevalent in the Amish community. So 1 out of every 200,000 births, but most of those are going to be in the Amish community because they are such a closed community in terms of relations. It's usually going to be associated with short limbs, polydactyly, congenital heart defects, and they have normal intelligence and development. So it's really kind of just a physical condition for these patients. And then just kind of almost lastly here, we have our VATER association. This is also known as our VACTERal association. It's an acronym for combinations of these abnormalities. So V, we have vertebral anomalies, A, anorectal atresia, C, cardiac abnormalities, T and E, tracheoesophageal atresia, renal abnormalities, and limb abnormalities. When you have a baby that has a minimum of 3 of these characteristics, and we kind of have an unknown reason why, or genetic testing is undetermined, we consider that VATER or a VACTERal, depending on what they have, what the combination is. The prognosis, of course, for that baby is going to depend on the severity of the occurrences, but also the combination of them. It's a random genetic event, so there's not really anything that we can look back at, but there is a higher risk of having this if you have a family history of any of these conditions. And again, certain environments can cause that as well. So, if you're living in an environment that doesn't have clean water, clean air, sewage, things of that nature, that all can have an impact on the development of these systems, and therefore subsequently the development of these abnormalities. And then lastly, we have fetal alcohol syndrome. We've all heard of this before. This is when the mom is drinking alcoholic products to excess during pregnancy. The characteristics of these kids, they are going to have IUGR. That's a pretty standard one. They're very small. These babies are so small. There is a mental deficiency or delay with these babies as they grow up and develop. They usually have very small heads, so microcephaly. They have genital anomalies, so their physical reproductive organs are abnormal, and they have cardiac defects as well. So very unfortunate, but luckily very preventable.